Okay, we need to start. Nipun, is ma'am there? Should we start, Nipun? Is ma'am around or should
She is
we?
coming in 1 minute only.
Okay.
Link is not opening actually. She wanted a new link.
Should we start, Nipun? Is ma'am around?
Hello, good afternoon, everyone. Hello.
Good afternoon.
Hello.
Good afternoon, ma'am.
Good afternoon,
Good
ma'am.
afternoon, sir.
Hello. Good afternoon.
Hello, good afternoon, Dr. Srinivasan. Nice to have you here.
Yeah.
So I think we'll now be starting with our second day's program. And I think it is time to start. So Nipun, should we start?
Yes, ma'am.
Yeah.
Just a prelude. So, yeah, Dr. Nipun will be talking about breaking bad news or what we also call serious illness communication, which is a very important topic, and it comes up always in during when we're dealing with a sick patient.
Just a second. Can you see my slides?
Yes.
Yes, Nipun.
Okay. So at the outset, I would like to thank the whole team of Medical Communication Workshop for giving me this opportunity. And I really thank our Professor Geeta and Professor Meenu Singh and whole team that they are helping students, residents, as well as physicians, including myself, in improving our patients' healthcare using such medical communication workshops in our day-to-day practice. So topic assigned to me is breaking the bad news. And as you can see in this cartoon, it's a distressing task for every physician as well as a resident during their training as well as post their training that they face such situations of delivering bad news. And sometimes not only the patients, but also the physicians are in a state of high emotions, how to deal with the difficult situations of delivering bad news. So there are no disclosures pertaining to my task, my talk, and there are some pictures which have been taken from the internet sources. So in next 15 minutes, I'll be addressing certain issues. First and foremost, definition of bad news. Why is it important to understand the how to deliver the bad news? Is there any difference between the Indian setup and the Western setup? What is the amount of information to be given to the patients or the family members? What is the role of family in making the decision-making process, as well as in the phase of delivering bad news? Who should be the messenger of bad news? how to deal with the emotions resulting out of this process, and finally giving you the spikes protocol, which one should remember by heart and practicing it daily so that it becomes a habit. So let me give you first a case which I myself encountered during my residency period. I was a new second year resident joining in emergency department. I was very enthusiastic dealing with the patients. 16-year-old boy came to me who was a single child in the family with dengue shock syndrome. I tried to manage that patient, intubated, resuscitated, tried to find a bed for that patient also, talked to the consultants. But meanwhile, patient collapses and dies in emergency department despite a full CPR. Family was given the death news in a hurry because there was a lot of rush in our medical emergency. And then there was a lot of drama, a lot of crying, a lot of emotions in the family as well as with myself. I was feeling so bad that I could not save a single child. There was no senior around as it was a lunchtime, and it was so distressing situation for me that if I were to be told that how to break a bad news during my residency prior to this posting or during my medical school, I would have been in a much better situation. I would have been much calmer and would have delivered the news very effectively. Another case which I have found 10 years down the line after my residency now, another 60-year-old businessman who is incidentally found to have a non-alcoholic steatohepatitis related cirrhosis of liver with multifocal cancer in the liver with metastasis to lungs, lymph nodes, and portal vein. And we know that it is an expected survival of 6 months. Then how to tell to the patient? Family here doesn't. Family here wants that the patient doesn't do not know the diagnosis, but actually patient wants full diagnosis and full information. So in this situation, it becomes very difficult and crucial how to break the news to the patient, despite that the family doesn't want that patient should know the complete diagnosis. So by the end of presentation, probably I would give you some message, some orientation, so that you understand the basic principles how to break the bad news and maybe effectively deliver such news. So what is bad news? So any news which adversely affects the individual's view of his or her future. So it may be temporary or it may be a long term. It may be a mild of severe, it may be of mild severity, or it may be a very grievous like death. It may involve short-term disability in terms of loss of one limb, or it may involve a chronic neurodegenerative disorders which may last over a person's life. So a bad news can be anything, but which affects the individual's view of his or her future is called a bad news. So as a resident, we join very enthusiastically in medical profession, thinking that we will take care of all the patients, we will cure all the patients, and everything will run fine. But once we encounter these situations, these difficult situations of sudden death, sudden complications in patients, we find ourselves in a difficult situation. And this situation may be difficult not only for junior guys or junior physicians, but also for senior physicians as well. So what to do in this situation? So before embarking upon the different steps of breaking bad news, I would like to tell you there are certain barriers in effectively delivering the bad news. As you can see in this cartoon, a surgeon is just backing the news on the patient's relative, saying that it is about your late husband. And in another cartoon here, he says that I'm afraid that your father is dead and dead as dodo. But there are certain issues, certain barriers where we have to see when delivering bad news. There may be problems with the personality of a doctor. A doctor may not be able to give the diagnosis in a format which is effective. Maybe he has not undergone a clinical training for the effectively delivering the bad news, and he lacks the skills. Personality issues may also be there at the level of patients as well as the families, that they may be very anxious, they may be very outrageous, and they may not accept the diagnosis if they are already depressed or anxious, or maybe some underlying hyperthyroid or thyroid issues in some patients. There may be a possibility that a physician who's not effectively delivering the bad news may not have got the good role model during his training or her training. There may be the differences in the expectations of the patients as opposed to the doctors. Patients would want that they should know the diagnosis. The diagnosis should be clear, should be given in a sympathetic way, and doctors should care about their diagnosis. But on the other hand, doctors may be in hurry. They may not give a full diagnosis and in a complete structured way, which I'll be telling you in subsequent slides. There may be feelings of mistrust, anger, fear, and blame amongst the family or the patients. And sometimes there may be interference of family in effectively delivering the bad news to the patients. And again, in this cartoon, you need to understand that patients sometimes may know that they are going through a difficult phase of disease, and a doctor should be humanistic, and he should not whack the news or deliver the bad news directly in a incompassionate way to the patients. So why is it important to learn breaking bad news during your profession? It is an important skill, yes. According to one study, 96% of the residents were needed to break bad news during their residency period. So it is important to learn this skill. It is stressful task for both, as I've given you examples at the outset. And the discomfort is maximum when the doctor is very young or the patient is very young or the diagnosis is very grave, which was there in the case with NET1 also. And the outcomes of breaking bad news may be a denial, anger, anxiety, dissatisfaction, hopelessness, and depression, which is many times difficult to handle by a young physician. So let me give you an example why breaking bad news is important. So going by this research way back in 1986, the long-term outcomes of poor delivery of breaking bad news was associated with twice more episodes of depression and anxiety. Here, what they have shown is that the cases of carcinoma of breast who were given inadequate information during their disclosure of diagnosis, and once they were followed up after 1 year, they showed that those persons who were given inadequate information had a higher incidence of depression and anxiety. So does training improves the satisfaction levels or the outcomes of breaking bad news? The answer is yes. And according to this study in 1984, the Cunningham's model was used, which was unhurried, honest, and balanced, empathetic way of delivering the bad news when compared to traditional approach in family counseling for the babies of Down syndrome. And they found that the satisfaction rate amongst the family members was close to 100% compared to 20% in those who were not delivered the bad news in a proper and structured way as can you listen to me?
Yes, Nipun, yeah.
Okay. So somebody muted me. Okay. Then moving ahead. So is there any difference in the Indian setup or the Western setup where the expectations of patients or families are different? So the answer is, in the initial studies, we found that around 60% of the patients would want their full diagnosis in India compared to the 94% in the patients in the Western setup. And around 2/3 of the patients again wanted that their family should know the diagnosis first. But mind you, this scenario is changing, which I will be telling you in subsequent slides. And in that study, they found that the patients who wanted the full disclosure were likely to be more educated, employed, and proficient in English language. And despite everything, around 1/3 of the patients did not want their full disclosure to be made to them, despite being aware of their diagnosis. And there could be many reasons for that. And most importantly, the hopelessness, denial phase, or maybe they wanted the diagnosis at a later date. And according to this study in 2013, majority patients, 94% of the patients wanted their diagnosis to incomplete, and 85% wanted their diagnosis to be told every week by week when they took the patients of cancer. So is there a congruence of decisions between patients and families? Yes, for the Western setup, but no for the Indian setup. For the Western setup, 95% of the times there is a congruence of decision that yes, patient also wants the full disclosure, and as well as the family wants that the patient should also know the full diagnosis. Whereas in Indian setup, the congruence remains in 60 to 72% of the times, whereas it may be dissociated. Sometimes patients doesn't want the full disclosure, but the patient's family wants that patient should know the diagnosis, and that could happen in 40% of the times. On the other hand, there could be a possibility that the patient wants the full disclosure, but patient's family doesn't want that the disclosure should be made to the patient. And that is the case with net 2, which I was telling you. So this can happen up to 30% of the times in Indian setup. So what are the basic principles to effectively deliver the breaking bad news? You need to understand in what setting you are trying to deliver the bad news. Is it an ICU setup where the patient is already there with you for the 3 or 4 days? We are constantly telling the patient's prognosis every day, and now the patient dies. Or is it an emergency department where you are looking at the patient for the first time and patient dies? Or is it a teleconsult, which is an emerging area, and the delivering bad news on teleconsultation is a topic in itself. Was there a previous contact with the patient, or is it a de novo consultation, de novo breakage of bad news? What is the level of expectation of patient or family? If a family or patient is already accepted the diagnosis, which is a bad news, you may be easily giving the diagnosis. But sometimes the acceptance level may vary, and that creates a problem, effective barrier too. And how to overcome that barrier, I'll be coming to in subsequent few slides. What is the severity of disease? Is it the disease which is affecting the short-term prognosis, or is it affecting the long-term prognosis? Because the way of modulating the voice, the pitch, as well as the clinical content would vary. What is the age of the patient? Suppose a patient who comes to you with malignancy at a terminal stage, and the patient's age is 80 years. Patient has already accepted that he is going to die, and maybe he will be more acceptable to the diagnosis compared to the person who is a 20-year-old guy and who need to be told about his chronic neurodegenerative disorder. There could be a possibility that diagnosis is in evolution, and yet the diagnosis is not achieved. And you need not to disclose everything regarding a disease or a diagnosis. Like, say, for an example, when you are trying to differentiate a lymph node which is tubercular versus malignant, you need not to tell everything regarding the tumor and the malignancy before the full diagnosis is achieved. Baseline knowledge of patient and the family members need to be assessed, because nowadays you will get a patients or the family members who have Googled the diagnosis. They know most of the things. They have consulted outside, and they know many things before they come to you. And that can be helpful also and disastrous also in both the situations. You need to respond to emotions and need not to react to emotions. By this, I mean that there will be emotions when you tell bad news to a patient or a family member. You need not to react to anger or anxiety. You need to respond with empathy and care and respect. Do not fear your emotions or criticism which is being posed to you. Maintain your calm, and because the emotions will be there. As a human, we always have our emotions, but we need to control and to tell them in a structured and balanced way the diagnosis, so that the long-term the psychosocial outcomes of patient and patient family members, as well as for the physicians, remains true. And you need to understand that there should be a safety of yourself while delivering the bad news. And once you are in a situation which is difficult and you feel that there is a difficulty, you may postpone or ask the help for a senior. So how much should a patient know? Is it a patient's wish, family's wish, or a doctor's wish? The recommendation says that it is the patient's wish. The recommendations are best practice statements. These are not evidence based. Let me be very clear about that. But as per the legal requirements of India, a draft of patient's charter in India 2018, you need to tell the complete information to the patient and in a clear way. But again, you need to be compassionate about the diagnosis, and you need to give the information in bits and pieces rather than just whacking the whole diagnosis and prognosis to the patient at the first outset. Should family be informed first or the patient? The answer is ask the patient what do he want. First to inform him or does the family, and then secondly, how much he wants to know. And here the role of treating physician is very crucial to give the information in a staggered way. Who should be the messenger of bad news to the patient? Is it the nurse, the treating doctor, the physician, nursing attendant, or a resident? The answer is treating physician who is in charge of the patient should ideally give the full bad news to the patient. And residents who have undergone the training in breaking bad news, the basic understanding of the structure of breakage of bad news can also deliver bad news. And this sometimes is mandatory once you are posted in emergency and there is no senior around, especially in the case Vignet 1, which happened to me at the outset. So how to deal with the emotional response? The three critical steps, three critical components are empathy. You need to show that you are in the, you have to put yourself into their shoes and understand how much and what they are feeling. You have to show the care to the patient that you care about their disease, their diagnosis, and their prognosis. And you have to respect to their emotions, whatever they are feeling. That is how these three critical components you can be able to effectively deliver the bad news. So let me give you the spikes protocol, which was originally described in 2000. And this one resident should remember by heart, and you have to practice it many times so that it becomes a habit for you. Because this skill is learnt over a period of time. You see a lot of your seniors, you practice these skills, and then you master these skills. And it is not a one-day job or a 15 minutes lecture that you will become a masterly in breaking the bad news. So according to this protocol, S stands for setting up an interview at the outset. Second is the asking for the patient's perception. I stands for obtaining the patient's invitation. K stands for imparting knowledge or information to the patient. E stands for the dealing with the emotions. And S stands for planning the strategy and finalizing summary of the news. According to S, we need to set up an interview which is where there should be a privacy. Involve the significant others who are, if you feel that it is not a safe conversation, you need to sit down and make an eye contact with the patient and manage the time constraints and interruptions. If you are expecting, suppose you are in an emergency setup and you have only 5 minutes to tell to the patients, then you need to tell them very clearly in a separate room, maybe in a resident room, that I am having time constraint because I am facing so many patients in the emergency, and you need to tell them at the outset that this is how I am going to tell you. So setting up an interview is a very important step, critical step in starting this conversation regarding breaking bad news. Second most important is asking the knowledge about the disease, knowledge about the prognosis, what they already know, what jumbled up brain connections they have made already using Google or whatsoever, any other source. And then you have to assess their socioeconomic background, their education, their occupation, because the things you are telling will be in their basic vernacular language, and so that they understand what you are telling. You cannot tell a very scientific hi-fi stuff to a person who's totally illiterate, living in a rural setup and who doesn't understand any medical term. Okay. Then invitation, asking the patient's wish, how much he wants to know, and whether he wants to know first, or he wants that the family should know the first. Then impart the knowledge in very empathetic and respectful way, with a careful selection of language. You cannot be very hilarious about telling a diagnosis. You should avoid the medical jargons. Importantly, you should give a warning first. You can start by saying that I am very sorry to say, unfortunately, I have a bad news for you. That is how you can start. And maybe you can also tell that is what can you do about it. You can't just say that nothing can be done about it. There is always something which you can do about it, and there is something called palliation and hospice care which you can provide even to the terminal patients. The pace at which he understands the knowledge should be given in that pace. He should be given in a staggered information and repeated checking for the feelings. And it is again always a trial and error kind of phenomena, and it is learned over a period of time, not within 15 minutes. Then dealing with the emotions, I already told you the three key components: observe their emotions, identify the reason why the emotion is there. There can be the reason of anger because he was not being told the diagnosis in the previous 5 months, and suddenly if you back the diagnosis of malignancy on the patient, that becomes sometimes very difficult. So you need to understand baseline knowledge, and then how to deal with these emotions is with three key critical components: empathy, care, and respect. Then finally, making a strategy and shared decision making, giving them the options, benefits, and risk of every possible solution to that problem, and make a shared decision making. And finally, must understand, must check what they have understood, so that there should not be any disconnection between the two. Finally, if there is a conflict situation, which I mentioned in case Vignet 2, this shows that first conflict situation where patient wants the full diagnosis, but family this is the most common conflict, and but the family doesn't want that patient should know the diagnosis. Again, in this situation, you need to assess why, because sometimes it may be possible that patient is very emotionally labile, and family knows that if you tell them the diagnosis of malignancy or a terminal stage disease, he may go into denial, complete depression, he may not eat food, and that could then inadvertently affect the outcomes of the patient. So again, here the approach is ask the patient how much he wants to know. If he wants to know in a complete diagnosis and prognosis, you need to assess his socio-economic background and the emotional status beforehand, maybe asking with the family first, and then giving him in the information, not in a 1 day, maybe in a 2 days or 7 days period, and in a very empathetic way, feeling that I am not having a good news for you, and maybe there are some you can say like patients having cancer, you are having some gant in the liver, you may be having some guilty in here. That is how you can modulate the things and tell the patients in a very vernacular language. But again, in Indian setup, you need to tell one person, key person from the family, a full disclosure, full outcomes, full differential diagnosis, and full treatment options. If even if the patient is not willing to know all the full diagnosis. In the second situation, there can be that patient doesn't want the full diagnosis. He may be in a phase of denial that he doesn't want to know anything about it. But patient's family want that patient should know about his diagnosis. And again, the literature suggests that things have to be disclosed to the patient. And again, in a multiple ways, you can give it. You have to tell to the patient that yes, you are having this problem, and you need to tell maybe on repeated occasions regarding the disease. And finally, what are the future prospects in breaking bad news, and what is the evidence so far, empirical evidence so far? By this, we mean that there is a systematic review in 2009. Over the 10 years, they found only 245 articles. Around 55% of them showed only the new data. And miserably, only 16% of the studies on this topic on this regarding breaking bad news were on the interventions done, and more so these interventions were done on the physicians to improve their skills of breaking bad news. And less than 2% of the studies, 1.6% studies, only 4 studies were actually focusing on the actual psychosocial outcomes of the patients, which is the most important thing out of this whole skill of delivering breaking bad news. Ultimately, it is a patient-centered outcomes, and you need to improve their long-term and short-term psychosocial outcomes while delivering the bad news. And let me summarize by saying that this is a spikes protocol. You need to understand the setting and ask for the perception, then ask for the invitation, see the knowledge, show them empathy, and finally summarize the results. Thank you very much.
Thank you, Dr. Nipun, for a very nice presentation. We have actually overstepped about 10 minutes. So, and anyway, those of you who don't know Nipun, he is assistant professor in the Department of Hepatology and has been associated with this program right since its beginning. Right now, there are no questions, and I'm sure the questions will come towards the end of this session. And this session will comprise of the next talk. That is by Dr. Param Kharbanda. That is about difficult interactions and shared decision making. So Dr. Param Kharbanda is Professor of Neurology in PGI Department of Neurology, and I now invite Dr. Param to give his talk.
Thank you, ma'am. My pleasure to be associated with this wonderful team and wonderful program. Thank you very much. By the time I share slides, I just wanted to make quick points about the breaking bad news which came to my mind. So the basic thing, you know, what happens is that as healthcare professionals, whether doctors and or nursing, any staff, we are always told to save lives, save lives, save lives. So in that mindset, we forget to think about death. And that is a big handicap sometimes, especially in palliative care or something where you're dealing with sick patients. It's a big handicap that we are never trained to talk about that. And even culturally, talking about death, especially in our culture, is a taboo. So these are few things we need to encourage to be talked about before we can do our best in the field of breaking serious illness communication. So going on to my topic, which is another important thing, and you know, it's kind of upcoming in our setup, shared decision making, and let me just take you through this. So this is a small mnemonic I made because it's important to have these before we go on for shared decision making. So I call them 4 C's of communication. The one is candid. It was briefly dealt yesterday also in talks. So what we're trying to do here is we're trying to twist the style of telling, as Nipun just said about that giving properly serious illness and bad news. But we must remember that we are not twisting the facts. So this is very important that we play it well, we make it the blow soft, but do not twist the facts. We will need to convey the exact prognosis the best way we can. The next is about clarity. That means not using too much of medical lingo, as we keep talking in so many, you know, myocardial infarction or, you know, neuropathy. So we need to talk in patients' language when we are trying to get to make them good decisions. It has to be concise, not information overload, and complete in the same way that we don't leave out any important stuff. So I'm just starting with a small case scenario. There is a 28-year-old accountant who's well versed in English, had a first tonic-clonic seizure recently, and after significant sleep deprivation came to discuss the management plan with us. So as a doctor, what is going through we want to do? We are wanting to do the best for the patient. So we want to convey the diagnosis. We want to start appropriate treatment. We want to make the patient seizure free and ensure compliance to the prescription. But is it what is the same thing going through the patient's mind? Of course, all these things the patient is also worried about, but there's a lot of stuff which sometimes we don't see, which is going on through the patient's mind. How long will I have to take this medication? What will be the side effect of this medication? How will this alter my life from a partying person, young person, to not take alcohol or not go to late night parties? What are the limitations? What is the limitation on driving to me? So all these things are going on. So unless we are sensitive to these, we'll be just focused on giving medication. And that is what shared decision is all about, to know from patients what they really want. So I'm just going to play a short video, which is like the ineffective communication style. I hope you can hear the sound. It confirms that the episode you had was a epilepsy. Sorry, go back. Were you able to hear the sound?
Yes.
Okay, I'll go back.
Yes, beautiful.
It confirms that the episode you had was a epileptiform seizure.
Okay. So what do we do for that?
You'll have to take anti-epileptic drugs, which will help you in stopping the seizures.
And that would be for how long?
It could be 2 years, 3 years, sometime even lifelong.
And what if I don't want to take that?
What do you mean, don't want to take? You have to take drugs. You have epilepsy, you have to take drugs. I mean, if you don't want to take drugs, I don't have any magic where I can make you well. I mean, then you probably wasted your time coming here, and mine too. So you see, this is what we call, I mean, we've all done at some point of in our lives and have a tendency to do it in busy clinics. What we call is paternalistic, that my way or highway. I tell you to do this, you take it, or you just go and talk to somebody else. I am not willing to talk to you beyond that. So this is something, too much of a power difference which people felt. And slowly we came towards what we called as informed medical decision making, where we give them proper information, give them the options, and then the patient makes a selection. So that is desirable. That is something I think most of us who are aware about things are at. But shared decision making is something which is a step beyond this. So as you see, instead of two one-way lines, this is a two-way information. So we do the informed medical decision making, but to that we add values and preferences of the patient. What would they want? Which would be best suited for their lifestyle, even if it is at a difference from what we think is the best treatment. So this is all what comprises of shared decision making. So the framework for that, what we call as a share model, which you can see on your screen, is SHARE. Seek is for patients' participation. So we want them actively participating than being a passive person in this. We help them explore and compare treatment options, which means that we need to give them clear and factual knowledge. Our facts need to be clear about the things so that they can make a very informed decision. In addition to that, see their values and preferences. What do they think about life generally? What do you think, what quality versus quantity of life? All these things. So unless we spend time and talk to them, we won't know what is best suited for them. And then we reach a decision along with the patient, and then we evaluate. Of course, we give them our point of view that, okay, this is what I would feel. Maybe this is what we can do together. So as I said, it's a bi-directional flow, where the clinician offers the options and gives all the risk benefits, patients to set their values, and each participants get a better understanding of each other. The best part is there's a shared responsibility. Once you make a shared decision with the patient, they feel responsible, and there is a less of skirmish or later, medical legal things that I was not told. And I mean, I would have, if I was told better, I could have chosen something else. So it decreases our risk and responsibility also. And of course, if it is clear, it can avoid unnecessarily overdiagnosis and interventions in these patients who may not want them. So this is this thing of the same scenario done in a better way. The treatment for that is anti-epileptic drugs, which you have to take regularly.
And what if I don't?
If you don't take drugs, then there is a 50% chance that you can have seizures again. But that means that there's also a 50% chance that you may never have a seizure again, even if you don't take anti-epileptic drugs.
So can I get injured because of this?
You can, but mostly, most of the seizures don't have grievous injuries. They are small things like tongue bites or even abrasions. But about 5% of people can get seriously injured during a seizure in the form of fractures and even burns. It mostly depends a lot on your lifestyle also. If you are driving or swimming or undertaking adventure activities, your risk may be more. What exactly it is what you do as your job?
No, I just have a sitting job as an accountant. I don't drive, I don't swim, so
But then your risk may be lower. Although we can't guarantee that if you have a seizure in an awkward position, you will not get injured. But compared to other people, your risk may be lower.
so are there any side effects of these?
There are cognitive effects and sometimes a bit confusion after more in the beginning of a treatment and later over time. So what do you want to do?
No, actually my job is very sedentary, and I'm sure my work as an accountant will suffer if I have these, cognitive side effects as you told. So I think for now I will postpone my anti-epileptics.
So there's actually, I have a booklet which you can read, and this will tell you more knowledge about the disease and possibilities, and when you come back again we could discuss that again.
Thank you.
So as we see, by spending and knowing the patient's background, their priorities in life, we could make a better decision rather than just imposing a decision upon them. But then there are challenges. I mean, now everyone who's seeing as a medical professional is aware of these challenges. It's like doctors that I already said. So patient may be unable to take decision. Many times it happens, that we tell all this and the patient says, Doctor Sahab, aapko jo theek lagta hai kar do. I mean, whatever you feel is the best. That is also again a cultural thing because people are not trained to take tough decisions. So we may find it very difficult to make a shared decision with these patients, because they have not been in the scenario before. I treat epilepsy every day, but it's very new for them. This is something, a screenshot from my phone where I was not very good at this making online payments. And suddenly I was making an important payment and this thing came up. Cancel transaction, this would cancel your ongoing transaction. But below that it's cancel or okay. So do I cancel? It gets canceled. I say, okay, it gets canceled. So I was not the doctor there. I was not a specialist. So I got very confused. And then my son was there. These kids are very good at it. And he came and he says, Dad, you just press cancel. That means this box will go. I couldn't do it. He just came and pressed cancel and it was all fine. So sometimes we need to take these people by their hand to make the decision. So if that scenario arises, what I usually like to do is, maybe if I was in your situation, I would have chosen A, B, or C. And because of these reasons, and tell me if it is okay with you. And obviously we have to get their permission in the end. So this is how we go through their challenge. Another challenge which we hardly talk about is patient priority when the thing they choose, now it's more in the Western society than our society, goes against their benefit according to us medically. Let's say I want to give a surgery and they say I want only medication, and I know the surgery is the only curative, otherwise this patient may not do well, and the patient sticks to their thing that I don't want surgery. That is where maturity of a treating physician who comes, that rather than what our impulse is to say, okay, then you go somewhere else. I mean, you are going to kill yourself. This is what we end up saying. So in that situation, the best thing we can do is to say, I strongly feel you should take this treatment. But if you choose to do this, it's your body. This is called the autonomy of our own body, which is a very important concept in Western countries, that I still am here for you. If you want to come back anytime, I can guide you to the medical treatment also, but this is going to be suboptimal. But I just want you to know that I'm here for you. This is not an easy thing to do, but this is what is going to help our patient better. Maybe the patient comes back. Unless we shut the door, patient might come back and choose surgery. If we shut the door by being angry with the patient, there goes our chance to make them well. And then there are challenges more from the patient side, where there can be fear, anxiety, anger, frustration. All these things which a patient is sitting in front of us, and we are normally as a 9 to 5 job, and they are very anxious. Their mind is clouded with so many anxieties and sadness from their disease that they may not be able to this thing. So we need to learn their anxiety, make them less anxious. This is a movie clip from a movie I recently saw. It's a Hindi movie where you can see the patient going through what are the thoughts going in her mind.
लेकिन इस हालत में उस वजह से मिलने से मैं डर रही थी. I guess हम सब डरे हुए थे. माँ बाबा को डॉक्टर्स के मेडिकल शब्दों से डर लग रहा था. जितना अच्छा डॉक्टर उतने ही कॉम्प्लिकेटेड वर्ड्स. बाबा सिर्फ सर हिला रहे हैं, पर उन्हें कुछ समझ नहीं आ रहा.
Isn't it funny? I mean, look at that. This person is not a medical or a communication expert. This is possibly a script writer who may have gone through such an experience in their life where the communication was found wanting, and this has stayed in their mind till they wrote these lines for the movie. So I found it very, related. So I thought I'll play this up. I think I'll end with the presentation so that if we have time, we can have some discussion on this. Yeah, I think we have time.
Thank you, Param, for a very lucid talk, and so very well presented the concepts which we want to tell our students.
Thank you, ma'am.
But very nicely told to them. Thank you so much. There are no questions in the chat box, and actually we are a little bit above time as well. But I think after Dheeraj's talk, we will still have time for, keep time for questions for all these 3 talks. Which are
Sure, ma'am. And we can have somebody look at the YouTube also. Yeah.
Yes. Okay. So Pankaj, please see the YouTube also so that we can take up the questions. And so thank you very much for the time being, and we will have you again so the next talk is going to be by Dr. Dheeraj Khurana. He is again also professor of neurology, and he is a stroke person. Like Param is an epilepsy person, Dheeraj is a stroke person, and he's also interested a lot in telemedicine, and he's running the tele-stroke service in PGI. So I'll now invite Dr. Dheeraj Khurana to start his talk. Dr. Dheeraj, are you there?
Yes, ma'am, I'm here.
Yeah,
am I audible?
Oh, yes.
Yes, thank you, ma'am. Thank you for the introduction. And it always is a pleasure to be part of this very interesting and I would say meaningful program, and especially in since it's been started in the last few years, its significance can never be undermined. It's a very important aspect of our day-to-day practice. So I have been interested with talking about challenging interactions, and as challenging interactions, a lot of aspects which have been covered by Param and the other speakers yesterday and today, they actually paved the way to have least conflicts in challenging interactions. And if we go by the principles as talked by Param, I think a lot of these problems which we face during conversations with patients would be settled. Now, talking about challenging, I'll just share my screen. Is my screen visible, ma'am?
Yeah.
Okay. So talking about challenging interactions, the first thing which comes to our mind is, especially with all the news which has been coming in the last few months to years, we've heard of violence involving doctors, and there have been protests all across the country with doctors demanding secure safety for health professionals, which is, of course, the right thing to do. But there are certain situations, I think, which should never light up or would never reach that situation where we need to be in a conflict. And it's a common tendency for when we hear such things that and we would possibly attribute it to a challenging patient. So rather than calling it a challenging patient, I would rephrase it as a challenging interaction of what I am supposed to talk on. And basically, this is to reiterate that we need to we get this attitude that it's not the patient alone who's always responsible. It may be some other factors. So first thing from our mind we need to take off is the patient is always not at fault. And he's already at a point, patients who come to us who are at a position which is not powerful. As if we talk of the power equation, doctors are always at a vantage point, and we need to acknowledge that fact, and we need to act mature and as leaders and be patient with the patient. So what makes an interaction challenging? There could be a number of factors as have been studied in the past. They could range from patient factors who could start with a hostile nature, disruptive, unpleasant. We see that quite often, but we really don't go into the background why this happens. It could be physician factors, for a doctor who's been running late, who's angry, who's hungry. Angry could have been because of issues at his department, at his home, a lot of things. A disease, the patient has chronic pain, difficult to diagnose or treat. And then there could be lack of support. The system doesn't support such kind of a situation. And your resources and the time is always a constraint. And especially in these current times, it's quite frustrating because we ourselves are faced with a very difficult situation considering the current COVID situation. So all the frustrating factors could worsen, and we could possibly be leading towards a challenging interaction. So first of all, these are certain examples. I'm sure each and every one of us may have faced one or the other. A very common one is a conversation with the patient following unexpected or adverse events. Now, these can happen quite often if you're giving a medication to a patient and then a patient would have all the questions. So that could lead on to a heated discussion. A patient, again, this could be a common scenario in the patient who's waiting in line with the kind of crowds we have in PGI. So we could identify with this kind of a situation where patients, due to a long waiting time, has been interacting with other people. He starts laying into you as you walk into the room, even before you start speaking. And sometimes you may lose your cool with such a patient. A family who's demanding hospital admission for an aging patient, where you know that may not really be helpful, and you do not want them to admit that patient. Patients refusing pay.
Sorry, interrupt. Someone has written slides are not visible. Okay, someone can somebody else see the slides, or everybody can see?
We can see the slide.
Okay.
I can't see this.
I think there may be a local problem, Dr. Subramanian.
Yeah.
All right. Sorry. Carry on.
Okay. And patients refusing to take a child or a patient who's home who requires an extra care, a patient who's demanding prescriptions which are not evidence-based. And very commonly we face that in our practice. Stem cells is a big example. In MS, every now and then a patient says, and it's a tough job sometimes to convince them not to take those unevidenced treatments. So another common situation could be a patient getting suspicious of some kind of treatment that you're especially instituting in an emergency. We face that quite often while we are trying to convince patients for thrombolysis in an acute stroke or thrombectomy in acute stroke. So that kind of a challenging situation, once you've been through it a number of times, helps you get practiced into probably reaching the right kind of a ground in discussing with the patient. So what is a conflict? It's been defined as a real or apparent incompatibility of parties' needs or interests. I think this defines it quite appropriately, because there is an incompatibility between either the patient and the doctor, and one fails to recognize it. It occurs pretty frequently, and especially in hospitals which like ours, where, and not only ours, healthcare has become complicated. So complex healthcare systems, conflicts are quite common, and this is evidence based. There is data to support it. And the worst part is, the conflict which takes place within the healthcare settings has a lot of impact, and there is data to support these facts too. And some studies which have been done show that 71% around, which is more than around 3/4 of the respondents, they observed conflict in the ICU in the last 1 week, and more than 80% were described as harmful, which clearly shows kind of the high incidence of such kind of conflicts. And another study which showed that 70% of physicians reported observing disruptive physician behavior at least monthly. And almost all agreed that such conflict do have a negative impact on patient care. So having a conflict or a challenging interaction not only affects your care of the patient, but also affects the smooth functioning of the system, your department. So it would be wise, I would say it would be useful if we were able to find a way through the conflict, not avoid, but find a way through and find a resolution of the conflict to help a smooth functioning of the system, as well as improved patient care. So conflicts in the healthcare setting, they may range from managing complex patients who could be a sick emergency patient, working in interdisciplinary teams. I can tell you how difficult it is, because you have to establish certain rules, ground rules between different departments. And this could actually lead on to somewhat conflicts. Implementing evidence-based guidelines on a system level. I'm sure everyone of us in our own settings would have faced these difficulties, because evidence-based guidelines are very different than a thought-based guideline or a thought-based treatment. There you may encounter physicians or colleagues who have a certain pattern of treatment which may not be evidence-based, and it is quite difficult sometimes to really convince a colleague into that kind of a evidence-based system, and these could be challenging. Now, a complex healthcare system usually exposes physicians, nurses, and administrators to conflict on a daily basis. This has been a well-documented fact, and we often face this in our settings too. And the worst part is, like I mentioned earlier, there are serious adverse consequences of healthcare, because if working of a physician is affected, indirectly you're going to affect the healthcare of a patient. So how do I handle a challenging interaction? These are just the gross points. I will take on in detail in the subsequent slides. A very important aspect is verbalizing the difficulty rather than just jerking off into argument. Look into the difficulty, consider explanations for the patient's behavior, because we possibly forget that the patient's anxiety levels and the state what the patient's mind is going through because of his family member getting affected, what he might be going through. So we need to consider explanations. Be an active, listening, empathetic doctor. Now that's empathy is what Dr. Vinita Surya also talked very nicely yesterday. So empathy and active listening is very important. Set the boundaries, find a common ground, and one would be able to really, solve the conflict and work together for finding a focus on the solution. So these are just a few gross points. Now, let's focus on the angry patient, because that's one of the most challenging situations that we might face. And anger is usually counterproductive, and it may not lead on to any solution. In fact, it may alienate people. It seems very energizing and leads on to a rage and impending violence. So let's look at this example of one of a hypothetical patient's situation. So if you look at all these things, the anger keeps on increasing. If a person who is at a senior position or at a stronger position tends to, rather than mitigating, he's worsening the scenario. So importantly, the anger should not be allowed to progress on to rage and impending violence. And one has to be very wary and identify signs of worsening anger and rage. Impending violence, there are some signs of impending violence. Why I'm talking of this doesn't mean that be ready to strike back, because if one tends to identify violence, the first thing that comes to your mind is, okay, I'm insecure, I'm about to be attacked, let's attack back. Now, the reason why we need to identify these signs are so that appropriate steps can be taken to mitigate damage, and also any kind of worsening of the situation. So signs of impending violence include verbal threats, belligerence, and intimidating statements. The most important thing is take the threats very seriously. Physical signs of violent confrontations, gripping fists, agitated movements, speaking through clenched teeth, and a paranoid stare. Now, these may be some of the signs. A body language of the patient or the person who's getting violent may change. But this does not mean that the physician who's handling such a patient should also get into the similar mode and take a face off. What needs to be done is have an effective solution. So when talking with someone who's angry, the most effective strategy is to acknowledge and try to understand their anger. That's the first step. And I think that puts in a lot of understanding into the mind of the person who's getting angry, and almost mitigates half of the situation. It almost, it can dissolve the anger at that point of time. So certain do's which one has to do is project calmness, be a empathetic listener. Of course, within a violent scenario, you may find it challenging, but that's exactly what a leader is supposed to do, be an empathetic listener. And focus is very important. One needs to listen very carefully and be attentive. So attentiveness is extremely important. If you are not attentive, the patient may feel that you're not actually listening to him and you're just looking here and there. One has to acknowledge the other person's feeling. That's again very important part of empathy. And then also establish ground rules if unreasonable behavior, because you cannot tolerate unreasonable behavior. In that case, you need to call security. So you need to call security. However, do not fall out of choices and just go into a conflict. Take time to do that. Always exercise restraint. Be reassuring. Accept criticism. Reassurance is a very strong factor which can help people understand and help patients calm down. Important things which should not be done are communicate in manners which are hostile, rejecting the patient's demands, stand in a challenging posture, criticize or act impatiently. And why I projected this image was, once you're faced with a violent situation, please don't start thinking of all the times that you've been in a threatening position and are ready to attack. This could be an example of maybe if you have gone to martial arts schools, do not think of attacking the patient back. So do not make false promises. Just a second. An important step towards conflict resolution is a mature leadership. And a mature leader who takes command of the situation should always take threats very seriously. And the leader should try to diffuse the situation by being non-threatening. So what needs to be done, even if you're faced with a very angry patient who's not treating you with respect, use a calm, controlled voice, and it should be clear and respectful. Do not try to undermine the importance of a patient. I know this video may not be exactly reflective, but what I'm trying to project is a calm nature of the physician or the leader is very important. Be at a buffer zone. Don't go back to your corner. Do not enter into the space of the patient, stay away from the patient, and ensure that no objects should be used as weapons which are readily available. And most of these steps should mitigate any worsening of the violence. And if it comes to really very threatening situation, security should be called, and the safety of the staff is a major concern of the leader, and it should not be allowed to worsen. The situation should not be allowed to burst out. So I'll show the case again, which I showed earlier, and look at all the points which need to be avoided. So a threatening patient in the ER, for example, this was the same case that I showed. So clearly what this behavior, which was meted out to the patient, needs to be avoided. So do not communicate in a manner that generates hostility, which was being done by the physician. Do not outrightly reject the individual's demands, and do not stand in a challenging posture. Again, do not criticize or act impatiently. Now, this, for example, this doctor who's coming out from the emergency seems very impatient. He does not want to listen to the patient, and he's trying to aggravate the situation by challenging the patient that he's not able, he has no business, no right, and no authority over him. So do not challenge authority. Very importantly, do not invade the person's space by getting close to the patient. This can be interpreted as a threatening sign and can worsen the situation. This kind of a interaction would definitely burn out into a very violent situation, and things can get out of hand. So what can be done is, like I mentioned earlier, and this. The first thing is, as a leader should be doing, projecting calmness is very important, and listening to the patient carefully.
से लेके आए हुए उसको कोई बता नहीं रहा है, कोई आ नहीं रहा है, आप लेके गए थे ना इमरजेंसी में उसको इलाज के लिए, उसका हुआ क्या है मुझे ये नहीं पता, सबसे डॉक्टर और वो सब अंदर लेके बैठे, पता नहीं जिंदा है कि मार दिया तुम लोगों ने।
आप मेरी बात समझने की कोशिश कीजिए, मैं आपकी
क्या समझो, तो कोई आ ही नहीं रहा, बता ही नहीं रहा।
मैं आपकी बात tries may get very belligerent, and he is actually trying to trigger something out of the physician too, because anger begets anger and it goes into rage. So as a leader, one has to understand and exercise a lot of restraint.
सकता हूं कि आपका बेटा बीमार है, इसलिए आप इस तरह से बात कर रहे हैं।
Acknowledging the other person's feeling can calm the person down.
आप मेरी बात समझने की और सुनने की कोशिश कीजिए।
ठीक है, बताओ।
आप धैर्य से मेरी बात सुनिए।
बताओ।
आपका बेटा बहुत बीमार था, हमने अंदर ले लिया है, इलाज चल रहा है, डॉक्टर्स की स्पेशलिस्ट की टीम पूरी।
Small specific requests, rather than ordering the patient, request the patient to be patient, and whatever seems to be the appropriate choice at that point of time, be reassuring, and accept criticism in a positive manner. Don't take it as a threat, or don't take it as a competition, as if the patient is trying to be disrespectful.
बेटे को देख रही है, वो पहले से बेहतर है।
ठीक है,
हाँ जी, पहले से बेहतर है। उसके ट्रीटमेंट के बारे में और उनका जो अब तक हमने ट्रीटमेंट किया है उसके बारे में हम आपको विस्तार से बताएंगे।
तो कोई आ ही नहीं रहा सर।
अभी तक सभी बिजी हैं, आप समझ सकते हैं इमरजेंसी एरिया में कि वक्त की थोड़ी सी मुश्किल होता है।
तो कोई ना कोई तो आके बताएगी।
मैं समझ सकता हूँ आपकी परेशानी कि आप इतनी क्यों इस तरह से व्याकुल हैं, क्यों इस तरह से बात कर रहे हैं। आप थोड़ा धैर्य रखिए, मैं अभी किसी रेजिडेंट को बोलता हूँ, वो आपको आकर के ट्रीटमेंट के बारे में।
हाँ, तो कोई किसी को भेजो
थोड़ा। हाँ बिल्कुल, आप
ठीक है, मैं बैठता हूँ, लेकिन
हाँ बैठिए, मैं आपको किसी को भेज रहा हूँ।
ठीक तो है
वो ठीक है, पहले से बेहतर है। ठीक है, मैं किसी को भेज रहा हूँ, वो आके आपको विस्तार से बताएंगे कि उनका क्या ट्रीटमेंट है।
ठीक है सर।
So very patient listening, reassurance by the doctor in even emergency situations, and I've just covered one aspect. This could be involving a patient who is suspicious of a treatment. That would be another aspect, but the principles still remain the same. Accepting all the questions, answering every question calmly, leads on to calming down of the nerves of the patient, and usually the situation will get mitigated and would not flare up as sometimes it does and leads on to adverse outcomes. So in the end, what I would just reiterate is communication skills are the basis of every conflict resolution, and it's important to establish and develop communication skills, as these are increasingly recognized to be essential and effective not only in diagnosis and management, and just as we heard Param and the other speakers, of shared decision making, even in having an informed consent, and so on and so forth. In every aspect, there's a communication skill which is involved, and if those at every step we are using a highly trained form of communication, which has also been proven, in all likelihood, we would not reach a situation where a conflict shall arise. And we also would like highly functional teams. And the usual attributes to the development of highly functional teams are an active listening. That is, again, as was discussed yesterday by Dr. Vinita Suri, you should be listening not just without attention, but actively listening and reflecting to make sure that you're understanding and demonstrate empathy to the patient, and effective delivery and receipt of feedback. Now, these are extremely important points, and all based upon communication skills. So with this, I will stop here and take up any comments or questions.
Excellent talk, Dheeraj. I think these are some of very commonly occurring situations, and I think the residents who are attending this course or would see this later on also on YouTube would really benefit from the kind of trigger situations which you presented and how to tackle them, and these videos, because these situations I know are very common in emergency where angry patients come and residents are equally angry, and sometimes it really leads to a lot of problems. There was some conversation going on in the sidelines of your talk between Dr. Srinivasan and Dr. Param. And would you like to say anything, sir, at this point of time? This is regarding being an empathetic listener and also the doctor being able to control his own emotions.
You're asking me to comment?
Yes, sir, because you have made some comments. I mean,
actually, all the three talks are extremely relevant, and that shows their experience in handling these situations and what to do and what not to do. What not to do was the first video, and that is always important in educating the students. Of course, this communication skill should be start right from the undergraduate days, and then, of course, I'll tell in the valedictory function other comments.
Thank you.
But I enjoyed all the presentations and their video clippings. Thank you.
Thank you. Thank you very much, sir. And thank you, Dheeraj, for a very nice talk. I think we'll have interaction later on. Now, the next speaker is Professor Indu Sen. She is Professor of Anesthesia, and she is now going to speak about the written informed consent and in medical situations. So, Dr. Indu, please.
Thank you so much, Dr. Meenu, for starting this session on communication skills. This is a much needed one. Am I audible?
Yeah. Yes, you're audible. There's a lot of echo. I don't know why. Maybe there are two mics which are open, or I think we'll.
Okay, I'll just set it right if I can. I'm sorry for the delay. Well, thank you so much for starting these sessions. And I also take this as an opportunity to welcome our newcomers to the PGI from the January 2020 and the July 2020 batch. And hope they have settled well in PGI during this COVID times, and they are working well, they are tuned to the place also. So my talk will be This is the overview I have. I'll talk a little bit about the history and then the definition, elements of written informed consent, then tips for obtaining valid, how we can obtain the valid informed consent, a little bit about electronic consent in this COVID era, and then summarize. The history dates back to the 4th century before Christ. In the Hippocratic writings, it was written that it is not desirable to involve patients because this might harm them psychologically in their decision makings for the medical management. And this continued till the 18th century, and it was told that we should avoid the information, giving complete information to the patients because this may upset them. Till the time in 1914, there was a court suit, Chandigarh versus Society of New York Hospital. This was a very old hospital, which was established in 1771. There was a female patient who had a lump in her abdomen, and the surgeon said that he is not able to differentiate clearly the characteristics of the abdomen, of the lump. So he wants to do an examination under ether anesthesia to find out exactly what it is. And the patient consented for the examination. During examination, it was found that this looks like a carcinomatous mass, and he removed that tumor. Now this patient went to the court saying that she consented only for the examination and not for the removal or the surgery. And in this particular case, the verdict given by Justice Cardozo, it went against the surgeon as well as the hospital. And what verdict was given holds true even in today's times also. The judge said that every human being of adult years in soul mind has a right to determine what should be done with his or her body. So, and a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damage. And after that, there were a lot of cases which are there in, if we look back into the history. And this is a recent one in Canadian Medical Association data published in 2016, where it was found that out of 65 cases which was there against the surgeons, the verdict came in favor of surgeons only in 21% of cases. So this is really alarming figures. And if we look into the Indian scenario, again, there are a lot of cases. And this is a verdict from the Supreme Court, which says that the patient should have the capacity and competence to consent, and his consent should be voluntary, and it should be on the basis of adequate information concerning the nature of the treatment procedure so that he knows what he is consenting to. So what is the clinical implication of all these cases? The consent became legally encapsulated. And now it is the physician's duty to disclose the nature as well as the consequences of the planned treatment. So in my previous speakers talked about shared decision making, the challenging decisions. So all these, they are legally also, they are important for us. So what are the questions? Was there a consent? And if it was taken, was it adequate or valid? So consent, informed consent is a moral, ethical, as well as a legal requirement. It is mandatory, except in the life-threatening emergency scenarios, where here also like brief conversations has to go on, and some important information need to be given to the family members so that they know that what is happening to their patient. And it must be informed, taken from a competent adult patient, him or herself, in the presence of a witness. When we call a patient adult, that means he has attained a legal age of 18 years. Less than 18 years, it is given by the persons who have got the legal responsibility or the parental responsibility, and it is called the assent. So let's have a look at these 4 lines. Do they tell us anything? There is no name of the child, name of the, like the disease is not mentioned, what procedure will be done, what anesthesia, nothing is written here. And even the person who is signing the document, what is the relationship with the patient is not clear here. No date is written. So this is not a valid consent. And this is what we have in most of our patient files. This is a blanket consent. Mind you, this is also not a valid informed consent. Though at many times I've seen residents telling me that this has written that also operation has been written here. So what it reads is that the undersigned consent to my admission to the hospital and to all examinations and tests and treatments recommended by the physicians, also operation if required. However, I understand that before doing any invasive procedure or surgical procedure or giving some unconventional treatment, specific informed consent would be taken from me. So we need to take a detailed consent whenever we do some major diagnostic procedure. So what are the elements of informed consent? There are certain preconditions. The person who is giving the consent has to be competent. Also, the person taking the consent should know what he is taking, and it has to be voluntary. There are certain disclosures which need to be included. Condition of the patient, what is the treatment plan, what are the benefits or the side effects of the treatment, what will be the outcome, are there any alternative options available, and if possible, what will be the cost. Then based upon that, certain recommendations are made of a care plan, and these need to be understood by the patient. And then having understood all this, the patient makes a decision, and then it is discussed again, and the written authorization is given by the patient to proceed. So we need to follow a detailed format. Again, if blood transfusion is to be given, separate consent is needed. Similarly, if there are certain special risks involved, like need for ventilatory support or ICU care, or the special scenarios where 2 lives are involved, as in pregnant patients, we need to take separate consent. And in the end, we must mention that all the queries of the patient were answered to their satisfaction. It's good to have a checklist because it's not easy to remember each and everything, and we might miss 1 or 2 points. Similarly, if you are publishing a case report and you need to show certain photographs, the identity need to be concealed. And again, we need to take a separate consent for that. For thesis purpose and other research projects also, we usually follow the ICMR guidelines. They are easily downloadable at various internet sites and even at our own PGI site also, website also. So having said all this, what is the current perspective? When we go through the files, we do find that many times the detailed consent is missing in the files. And the excuses given are, we are overworked, there's a lot of pressure, it is not practicable, not possible. And how can we define the risk only in percentages? Then how much we need to disclose? This is the most difficult question rather, that what all should be told to the patients, because if we start telling each and everything, this will become a very long document. My answer to all these queries is, let's have a look at this video.
विश्व स्वास्थ्य संगठन के अनुसार 8 से 38% स्वास्थ्य कार्यकर्ताओं के बीच अपने करियर में किसी न किसी समय शारीरिक हिंसा का सामना किया है। कई और लोगों को मौखिक आक्रामकता का सामना करना पड़ा है, उन्हें धमकी दी गई और मानसिक रूप से परेशान किया गया है। इंडियन मेडिकल एसोसिएशन ने बताया है कि 75% डॉक्टरों ने अपने जीवन काल में शारीरिक या मौखिक हिंसा का सामना किया है।
Dr. Dheeraj also shared very nice videos made in PGI, and the problems the residents are facing or the doctors are facing. in the challenging decision makings. So this is a very good article where tips are given for teaching the informed consent conversation. This is a good learning also, and the link is given here. So I'll briefly describe what is there. So the first point is we need to have thoughtful selection of the location for unhurried two-way conversation. This is doable, especially in this COVID time when teleconsultations are going on. Otherwise, in the busy OPDs and in the busy wards, it's difficult to find a place where we can just sit with one patient and explain everything to them. Take it as an opportunity for the patients to participate and tailor their decisions based upon their needs as well as the goals. Establishing trust or the rapport with the patients is very important. And those of you who attended yesterday's session, it was clearly told that the body language as well as the verbal and the non-verbal rapport which we establish with the patients, just 30 seconds to 1 minute taken to greet the patient, they go a long way to reduce their anxiety, as well as it has been found to improve their cooperation with the physicians. We need to communicate effectively with empathy, and for that we can follow ART approach, that is ask, let them tell what all they need to tell about their problems. Listen empathetically, but at the same time, keep on noting down the important and the relevant points from the medical point of view. So what you feel that they need to be addressed urgently. And then respond to them and tell that, okay, this is what I have learned. These are the list of problems you are having. We cannot manage each and every problem in one go. Let's handle them one by one. And then again, we can ask them that whether they have understood what we have told them, sort of closing the loop. Many times the patients will say, Doctor Sahab, aap bata do kya karna hai. So this is again another opportunity for you to tell them that from my point of view, this is the most okay. This is the problem which you are, which is really troubling you. Let us settle it first, and from medical point of view, let's take care of. Say the cancer is there. Let's manage this. इसका इलाज पहले शुरू करते हैं. So all these things can be taken care of. From the residents' point of view, you need to know the barriers to the discussion. The newcomers, when they come here, the language becomes a great barrier. They may not understand the local language, the Punjabi. And so you should know your limitation and tell your colleagues as well as the seniors that what problems you have. You will understand gradually, don't worry, but take their help. Similarly, many times the female patients, they are more comfortable if a female doctor is examining them. If this is not possible, have a female attendant available with you. The fifth tip is to review the core elements. A lot has been said about this also. We need to adopt to the checklists to find out what is the rationale behind, what are the benefits, risks, what are various outcomes, alternatives, and then the cost. Ensuring familiarity. Before you start facing your patients, you need to understand the problems yourself. You need to have your own list of risks, and mere theoretical or the bookish knowledge is not going to help. You need to discuss it with your seniors, and it's also the responsibility of the seniors that they must assess that have a mini role play with the newcomers. Then discussing risks is more difficult than discussing the benefits. And it has been said that the disclosures that a reasonable doctor would provide and a reasonable patient would like to know before making any shared decision. So it's not necessary that you need to tell each and every risk, and for the serious problems, percentages can be used, but be little diplomatic in telling those percentages, because say 100 में से 5 लोगों में ये होता है, but I don't know कि उन 5 में आप भी हो सकते हैं या नहीं भी हो सकते हैं. So This has to be, and again tell that it's not possible to tell each and every complication which can occur. So you have to be more realistic in sharing your knowledge. The tip number 8, that is discussing the circumstances. Here we talked about core elements. Then there are certain patient specific points, like say a patient is diabetic, having some heart problem, the extremes of age, then there may be some other comorbidities which increase the risk of the patient for a particular procedure. They need to be addressed separately. After all this, we need to tell our decision to the patient, and as Dr. Param also said and Dr. Dheeraj also said, that we need to use a simple language which we feel that our patient will understand. And many times we do have time constraints, and in these scenarios we need to modify our consent format based upon the time pressure, or you can allocate one of your colleagues to deal with the family and to tell them in detail what all is happening. The 11th tip is to discuss and review the documentation. So mostly it is point-wise documentation, but do mention in detail where if you have any detailed conversation with the patient, like the patient says that, okay, if you feel that I'll be cancer free if the surgery is done. So mention that the patient has told there are certain apostrophes or the clauses attached to it. And finally, this is done in a closed room with your colleagues, with your juniors, to review and debrief all the whatever the paper you have generated out of all this conversation. This will improve your future dealing with the patient as well as, but remember that we have to mutually respect our colleagues, juniors also. Currently in the COVID era, earlier we were told that we must empathize, hold the hands of the patients. But now that face-to-face confrontations are decreasing, especially in the operating room scenarios and in the wards also. So electronic consent is gaining popularity. It utilizes electronic tools to prepare interactive formats for the patients for explaining the relevant information and to document the consent also. But remember that whenever you are using these tools, we must inform the patients that, and as well as the whole team, that this conversation is being recorded, and they should know that even the relatives as well as the clinicians, that whatever they are discussing, that will be recorded for the like medical purpose. Advantages that we can review it later on and debriefing can be done. So what do we learn? We must have a detailed consent, have a your disease specific charts should be available, and there should be a general which can be modified based upon the disease specifics. We should have a templates. And if it's not possible that you carry these papers with you all the time, you can have screenshots in your mobile. And whenever you are writing this consent, that just check that you mention each and every point. To summarize, obtaining informed consent, take it as an opportunity to interact with patients, answer their queries, and make shared decisions. Keep your conversation simple. Use disease-specific templates, but they need to be tailored based upon individual requirements. Point-wise documentations, they complete the document, but narrations wherever required. And always review and debrief whatever you do for further improvement. These are some of the references which I have used. Thank you. Stay safe.
Thank you very much, Dr. Indu, for giving such a detailed information on informed consent. I'm sure the residents and everybody else has picked up all the basic nuances of taking an informed consent, its importance, and of course, how practically it has to be done. And of course, there has to be a pro forma which has to be disease and situation specific. and also age specific, I think. And for children, of course, we also stress on assent of children who can actually give assent, say beyond 7, 8 years of age, whether they want a procedure to be done or not. Again, we don't have questions at the moment, and we have actually overstepped. I think we have a lag of about 20 minutes now. It's kind of cumulative. So, so we'll postpone the questions and discussions to the end. I hope you will continue to be with us, because I know you're a very busy person.
Yeah, sure, ma'am.
But thank you very much. So the next talk is actually mine, and in that I have to talk about the social media and medicine and professionalism, how this is becoming important. I'll just share my screen. So can you see my screen now?
Not yet, ma'am.
Is it there now?
Yes, yes, ma'am.
Okay. So actually, I changed the title of my talk to online
You need to go
professionalism.
to slide share, slideshow, ma'am.
Okay, sorry. Thank you. Yeah. So I changed the topic of my talk. It has now become online professionalism. I know, because most of the courses which have taken place earlier, they were all in the pre-COVID era, when our online interactions were not that common, and we in telemedicine, we used to keep doing our teleconsultations, etc. But now that this modality became very generalized and worldwide, this issue of online professionalism has started emerging, and we now need to discuss about this part. So there has been a boom in online medical consultations. In fact, I was looking at one of the companies, telemedicine companies, who's showing increased profits, which are multiplying all over the time. But then to make these profits, I think they have to stick to certain guidelines, and they have to really make their consultations very useful and very ethical. So to become an effective teledoctor, one needs to have certain attributes and training. And to become an effective telecommunicator, you need to have several things. And those, as in rest of the professionalism, that you need to have your command over the subject. You need to also have a command on the language, because you need to now communicate with people, either with your language and gestures. And you should also be able to demonstrate empathy. And how one can demonstrate empathy through a screen is also something which needs to be learned. Then that is, demonstration of concern over electronic media has to be learned, and this needs social skills even in the face of physical distance. And how one is going to do that is something which is a matter of discussion. Not all the answers are known, because this is kind of evolving science at the moment. So essentials of teleconsultations are that patient data is in the form of an electronic medical record. Many times, when you start with, you've not seen the patient. You're just getting a record or a pro forma which has been filled up. The interaction between the referring doctor and the consultant is there usually when it is doctor-to-doctor consultation. There can be interaction between doctor and patient through video. It could be audio, and it could also be now Internet of Things, because we have several monitors which can be observed by the doctors, which are attached to the patients, and you can directly get that patient information into your computer. But still, this may involve history taking, inspection, palpation, etc. is usually not possible. But electronic examination is now coming into picture, and this may become a reality. And then there is a review of investigations. The visits are conducted with counseling about diagnosis and the future plan. That is the usual way, as we do for other consultations. But there also is involvement of tele-mentoring, because sometimes you're mentoring your other doctors who are referring patients to you about how to do things. So social media is something which can get active at all these stages of operation, because this is an online platform in which people are interconnected, like in the form of networks. So the opportunities for us are that the use of social media by medical professionals is now growing, because it has changed the way we communicate with each other, and we have much wider communities with which we can address. We can now share information, create content, have meaningful interactions, and collaborate in real time for professional and personal benefits. But there are certain challenges, and these challenges are that social media can raise some ethical dilemmas that you might have not thought of as part of your everyday use. Social media has the potential to blur the boundaries between private and professional. Because what we usually realize is that once we are on a social platform, we tend to become very impulsive, and sometimes we are putting on information which may not be required, or which may be sometimes objectionable, which is there on the social media. So there can be immense professional benefit by having an interaction through the social media and its presence through proper use. But inappropriate online behavior has the potential to undermine professional integrity, doctor-patient and doctor-colleague relationships, the employment opportunities and public trust, and in general, confidence in medical profession. So American Medical Association actually has come out with guidelines. And the first chapter which is there in those guidelines is says you are a doctor. You are always a doctor. That means even when you are on a social platform, don't forget that you are also a doctor and you have several responsibilities towards the patients and society in general. So as doctors and medical students, our professional standards must remain the same, whether we are communicating through social or through traditional media. And social media can raise some ethical dilemmas that you may not have thought of, as I told you earlier. So some people, the doctors are using social media for fun, like all of us used to have those Facebook accounts in which you will post your pictures, and some people will just give each and every detail of their daily activity. Then they were used for networking. That means there were several groups which were made in which you have your old residents, you have alumni, basically that was for social interaction and also for some kind of professional advancement, because you could get in touch with people whom you want to get in touch otherwise, and you've not been able to contact them for quite some time. Then some people used it for advertisement also, and because they would always tell, that this is what I have achieved, this is what this new procedure which I have done, or this is what I have discovered. This is like some people would even post their publications, they still do it on these social platforms to say that, yes, this is what I published. And it also is being used for medical data transfer. And we know that there were platforms in which patients were consulting their doctors. I know of a nutritionist who would actually, through the Facebook, actually interact with many patients and give advice, nutritional advice to patients. So these platforms were being used even earlier, but now they're being used with a much greater frequency. And in India, social media which are commonly used, which I'm aware of, I mean, there are several others, but Facebook, Twitter, Instagram, WhatsApp are something which are extremely, quite a lot in use. Now I want to just focus, some of these things which are occurring. I mean, I wanted to show a video, but there isn't enough time and to discuss it, how, this particular case has figured on the media platforms, which are not only television media, but also on internet, YouTube, and all other social media like Facebook, Twitter. There have been Twitter handles which have been created for this. So how useful that has been, or how difficult it has been for us as professionals to understand why we are sharing information, a private information of a patient who was killed or who died due to suicide, is something which has become like a public debate, and things which are reaching right up to the Supreme Court to decide what is appropriate and what is not appropriate. So this case, I think all of you know about this, so I'm not going to talk too much about it, except that we can have some discussion on this. But there are certain other case studies in which, say, there is a resident who posts a picture of himself with his girlfriend wearing his hospital OT greens on Facebook. Now, somebody might say, what is wrong in this? I mean, you can post your picture with you, but then those hospital OT greens would carry a logo of the hospital. And sometimes if the pictures are not very good, or even if they are good, it is something which you are doing for your personal matter. This is not something which you need to be doing. Then a senior doctor tweets a comment about a political party being involved, in a case like a murder. And that is, the case which I have just mentioned before, in which senior doctors have been tweeting on this. Then there's a Facebook live session which is conducted about a patient with a rare disease. And, you are discussing about a disease, about a patient, and totally forgetting that you have not taken consent of the patient, that certain thing. And even if you have taken the consent of the patient, it is something which cannot be done, under the current scenario. Then there is something like we were discussing yesterday. A patient WhatsApps the picture of, a part which may not otherwise be shown, of a breast lump, to a doctor asked for an opinion. And WhatsApp, I will talk about this a little more. Then a doctor posts a picture of a difficult surgery which has been accomplished by this person on an Instagram handle. So there are so many uses, people are putting them to, but without the consent of the patient, without the consent of the institutions, people are just taking things into their hands, and they can be branded as totally unethical. So one has to set up these limits. And at the moment in our country, we don't have a policy on the social media. Of course, with oncoming of online consultations, the government of India had come out with guidelines for teleconsultations. And in those teleconsultations, the government even approved the use of WhatsApp. Now, WhatsApp was something, which was really used in our, even in our hospital, where, a card is made and then a WhatsApp call can be done. But we all know, although WhatsApp messages are bilaterally encrypted and the information is confidential, but, WhatsApp is owned by Facebook, and all the information will ultimately go to their servers, and still you will not have a control over that information, and at a later date that medical data can be made public or can be misused. So the issues which are involved in use of social media for medical interactions is, one, its appropriateness; secondly, the ethics involved; then privacy and confidentiality of patients; and then misuse of patient information. We know that we are into a great mission called Digital India. And in Digital India, we are going to have, in our health and wellness centers, we are going to have patient information entered into a software. And that software is then going to be stored, those EMRs are going to be stored in National Health Stack, which is a centralized body for storing information on the clouds. And this information can then be used by artificial intelligence to make diagnostic algorithms, etc. So one has to be very, very careful about privacy and confidentiality of patient data, because that is something which, if leaked, can lead to a lot of problems. So what are the solutions for this? One is, of course, self-regulation. That is what we see. That is why we are trying to teach professionalism, that the same principles which apply to personal face-to-face interaction with patients, they do apply to online interactions also. The regulatory agencies like National Medical Commission, which was previously known as MCI, they would have to take action on all these issues as well. They have to frame guidelines for use of medical information on social media. The guidelines of American Medical Association can be consulted. Of course, that environment is very, very different, and the norms and the standards are absolutely very high over there. And we have to apply everything, in this changed ecosystem, which is now being called as the new normal. So, and I'm sure we are not going to go back to the old normal with this new thing coming up, because online consultations are certainly saving a lot of money of patients as well as of hospitals. So they will still be there, and one would have to see that. So this is the picture of this Guide to Social Media and Medical Professionalism by American Medical Association. It is available on internet. You just have to type the above website. So then I was to talk a little bit about video conferencing etiquette, because video conferencing is the second step after you have seen the electronic medical record of the patient. And there also, the doctors have to practice certain things, and things included in that as the dress code. You have to be kind of officially dressed for taking a teleconsult. Sometimes people put in their profile pictures if they are not dressed up, so that also has to be quite decent one, so that you look like what you are. And other thing is greetings initially, building the rapport the same way as you were doing in face-to-face interaction. Your eye contact, it becomes really difficult to have an eye contact in the online interactions, because many times you are looking at the screen, you're not looking at the camera. So you have to have devices in which, like people are now having this virtual reality studios in which you have camera which is embedded in the screens, but we have to make sure that if you want to look into the eyes of a person, you have to look into the camera. Then there are introductions, including disclosures, which should always be there. And especially in medical encounters, when you're talking to your patients, sometimes it becomes very difficult for patients to know that, is this the doctor I was supposed to be talking to? And hence, the guidelines by the government have made it mandatory that before you take on this kind of consultations, you should make sure that you display your MCI registration or your credentials on the screen. Then, of course, there are verbal and non-verbal cues, like how you're going to your gestures, your gesticulations. Of course, you can't hold hands with the patients, which you are not supposed to do otherwise also, I think. But your demeanor and your verbal cues have to be very, very empathetic. And of course, along with all this, one has to do efficient recording of data, which is extremely important when you're having this kind of interactions. So that's all from my side. We can then have discussion, but I think we will go along and have discussion in the end. So the next talk is, I'll stop sharing now and go to the next talk, which is by Dr. Mahesh Devnani. Mahesh, are you there?
Yes, ma'am, I'm here.
Yeah, thank you so much. So Mahesh is a professor in hospital administration. He is looking after the hospital management, and he is going to talk about medical legal implications and how they can be tackled by effective communication. Yes, Mahesh.
Yeah, thank you, ma'am. I hope I'm audible to everyone.
Yes, you are.
Good. Thanks again, and good afternoon, everyone. Glad to be here, the last session of the 2 days workshop. I hope everyone is enjoying it, and if there are any questions related to my talk also, I'll be happy to take after we finish. So in next 20 minutes or so, what I'll focus upon is how effective communication, especially in the healthcare, the medical communication, can help in reducing the legal complications. You all must have heard a lot about the Consumer Protection Act, the consumer forums, and recently there was an amendment also in the Consumer Protection Act, and there was a lot of hue and cry. But this is going to stay, and the healthcare going to remain in the domain, in the purview of the Consumer Protection Act, and we will continue to face legal challenges now and then. So it's important that we understand how communication is actually aiding in increasing these complications, how the miscommunication is actually aiding in increasing these complications, and how can we take care of those things so that we do not land into these legal complications, whether we are working as a resident, tomorrow we work in a government hospital, or maybe in a private hospital. So in next 20 minutes or so, my focus will be on these issues. So I'll not be covering any law or the Consumer Protection Act or the IPC or CPC, the CRPC, because for that you can attend a separate CME we organize on the laws applicable to hospitals. But my focus here would only be to let you know or understand how better communication can reduce the legal complications without going into the details of the law. So when we are presenting it face to face, I usually give time to the audience and expect them to guess from where these 3 paras I might have taken from. So I'll read it for you and then tell you from where I have quoted it. So the proper recording of events shall be maintained in the patient's file. That is date, time, name of examining consultant, resident with legible signatures. This should include communication with the patient or his attendants. Training of doctors, nurses, paramedicals, and class 4 staff to strengthen the communication skill is recommended. The condition progress of their parents or patients shall be communicated to the patient's attendant, preferably by the attending senior doctor or nurse on a regular basis. Now, what I'm quoting this from a very famous case in which PGI was one of the respondent. This was a case of an Amita Sarkar and others versus PGIMER Chandigarh. This case reached up to the National Consumer Forum, Consumer Dispute Redressal Commission. PGI actually, in fact, lost this case and had to pay to the father of the deceased, Amit Sarkar, because the lady had died in the trauma center of PGIMER, and these are the observations of the National Consumer Dispute Redressal Commission. And very important, what they are mentioning here is the training of the doctors, nurses, paramedical, and class 2 staff is necessary to strengthen. It is necessary to strengthen their communication skills. So that is what we are keeping in mind when we are organizing this, and we hope that while you are interacting with the patients and their attendants, and not just the patients but also the other providers, you will keep these things in mind. So let's have a little bit of see why these things happen and how these things happen. So there is this report of 2015 annual benchmarking report of the malpractice risks in communication failure. This is actually from the Harvard. And what they observed is that in 30% of cases of malpractice reports, communication was one of the major factors. And this communication failure is actually, majority of this is happening in the ambulatory setup, that is in the OPD, and this is from the US. This may not be the same in our setup. In our setup, it is possible that we have more communication failure cases in the emergency and then in the inpatient, and may not be that much in the ambulatory setup, though it happens in the ambulatory setup as well, because we see a lot of patients and we are not able to give enough time to every patient. So in fact, there is not much communication many times. So, but because the patients are not that much aware, and then though they are not, those cases may not be leading to the legal complications. But certainly in emergency and inpatient, we see that there is a lot of areas for improvement when it comes to the communication. Further, it tells us that it is not just the communication between the provider and the patient, but the communication between the provider and the provider is also very critical, because in 57% of the cases, the communication failure actually happened between the provider and the provider, and which ultimately culminated into some kind of a problem, some kind of a negligence maybe, or harm to the patient, and ultimately leading to a malpractice claim. Malpractice claim is similar to what we here see as the Consumer Forum claim, which are mostly not criminal. These are civil suits. So it is very important that the communication, what we are emphasizing here, is not between you and the patient only or their attendants, but when you are in the ward or when you are in the hospital, your communication with the nurses, your communication with the technicians, your communications with the residents of other departments, your communication with the non-medical staff, your communication with the administration, whenever it happens, is very important. And most important is between you and another resident, and between you and the nurses, especially when you are giving instructions for treatment, when you are handing over the patient, when you are transferring the patient, when you are transporting the patient. That is very important that all the instructions are given properly and the communication is proper. Otherwise, as this pie graph shows, that this might also lead to some kind of a legal complication for you. So what are the common breakdowns that happen? And this is again data from the same report. One is inadequate informed consent. This is 13% of the cases. An unsympathetic response to patient complaint. you will acknowledge that many a times patients are the first people or their attendants are the first people to tell you that there is some problem. And many times it happens that we don't, give heed to their complaint because we sometimes take this, position that oh, inko to nahi pata hoga, they don't know, they don't understand, they are just, this is their habit to, all the time complain. But that may not be the case all the time, because patient and their attendants are the first to see if something is going wrong. So it is very important that you give ear to what they are telling. Inadequate education regarding medications when we are not, communicating well about, especially if the medications have the very narrow therapeutic index or they are very dangerous, for example, chemotherapeutic agents. Incomplete follow-up instructions, no or wrong results given to the patient. This also happens many times. Miscommunication due to the language barrier, and this can happen anywhere in the world, and this can happen here also, where we are having residents from all over the country. And for that, PGI has a program where local languages are being taught. And if you're interested, you can further inquire about that, and we can give you information where you can learn Hindi if you're not well versed in Hindi. And if I'm not wrong, I think Punjabi is also being taught to the residents. So again, this may not be the same case in our setup, but in US they found that almost 1/3 of the cases were in general medicine, another 1/3 was in the cases of obstetrics, and similarly nursing and surgery, they were these types of cases were there. This is the complete report. If you want, you can download it from the link that has been given there. Now, if we have this kind of a concern where we know that the miscommunication leads to some kind of a legal complication, does having this type of a concern bring any change in the medical practice of the doctors? So the answer is yes and no. It does happen, and sometimes it is not that beneficial, because what it leads to is sometimes we follow the defensive medicine. So what happens that we are excessively referring to the patients. Now, then excessive ordering of the test and the use of imaging technology, that is the radiology or the nuclear medicine technologies. Excessive prescribing of medication or avoidance of certain patients or procedures. You might have seen many times surgeons don't want to perform some high-risk procedures if they are not sure about many of these things. So because when you are performing a high-risk procedure, it requires more of a time of a surgeon to explain it and take that informed consent. And we recently in PGI some time back did happen a case in one of the surgical department where the kid actually died, and a huge uproar happened. And this could have been actually avoided had a little bit more proper communication had happened between the treating surgeon and the parents of the kid. But worldwide, it has seen that when the doctors are concerned about the medical legal challenges, this actually leads to many beneficial. This has many beneficial effects as well. For example, it leads to more information being given to the patients by the doctor. The doctors are practicing more reflective practice, so they more see to what they are doing, and they are more reflective to their actions. Their greater sensitivity to societal and professional expectations and to the ethical concerns as well. They are more willing to make system improvements, such as developing audit procedures and better record keeping. This is one of the study from Australia in which what they did that they studied 3,000 medical practitioners, and they compared the group of the doctors who had experienced some kind of a medical legal matter with those who had never faced any medical legal complications. What they found that the doctors' concern about the medical legal issues does impact on their practice in many ways. Those who had faced some kind of a medical legal problem, they consider every patient as a potential litigant. And they relate with the patient more empathically. They provide better communication of risk to the patients. They disclose all the uncertainties around their treatment, as Dr. Indu was mentioning, that you have to tell them, but you can also tell them what are the various uncertainties, because this is not medical science is not a definitive science, right? Put systems in place to track test results. This is very important. Put systems in place to identify non-attenders. Although this may not happen all the time with us, but you must have seen that if the patients are not following up or if they are not following the instructions, you can always mention that in the card, in the records, that the patient had not followed your instructions or patient is not attending to your instructions. So put systems in place to audit practice. This is for the administration. Now, what are the effects of having this? So if there is defensive medicine, does it work? And if it works, does it, how it works or why it works? So the answer again is yes and no. Defensive medicine has been found to work to some extent. For example, in this Florida study, they found that the greater average spending by the physician was associated with the reduced risk of incurring a malpractice claim. What it means that the more the physicians were spending on their practice, it reduced actually the risk of incurring a malpractice. However, the principal limitation of this study was that the information on the illness severity of the illness was lacking. So it is very possible that the doctors, that the patients these doctors were treating were of high risk, and there was higher spending on the patients. So the higher spending though does lead to, it has been found that reduces the risk of incurring the malpractice claims, but it may not be the complete picture. However, several studies show that if there is a better communication between the provider and the patient, it does reduce the overall malpractice claims. In one of this study of 2001 from the UMHS, that is University of Michigan Health System, which had implemented a novel medical error disclosure program, what they found that it had ultimately led to significant reduction in the proportion of the encounters resulting in such malpractice claims. It reduced the overall time in resolution of such malpractice claims by almost half, and the mean total liability per claim also reduced almost to the half. So you can understand that if there is better communication, it actually reduces the legal complications of the doctors, of the hospitals. So why we are organizing this program today? So how making residents aware of medical legal aspects will help. So what we are doing here is we are organizing this training program, and we want that you are, in addition to the various forms of communication, well versed yourself with communication, but also are aware of the medical legal matters that arise during your interaction. This ultimately, we are expecting that will have some change in behavior. You will be more receptive to this change. It will lead to two things. One, defensive medicine, but at the same time, what we are expecting is that you will be more sensitive to the patient's requirements, and there will be better communication, and it will actually lead to the medical problems. So what we are expecting from you after this session is, after this 2 days of workshop is over. So you make yourself more aware of such kind of issues depending on whatever time you have. Discuss these medical legal issues wherever you come across, either on the social media or you read somewhere or someone forwards you. Try to understand what went wrong in these cases. Ask with your peers, discuss with peers. In addition to the medical knowledge, it is very important nowadays that we have such kind of knowledge. Read news items, read case studies, and if there are CMEs and workshops happening on the medical legal issues, make it a point that if you have time, you should attend them. So communication will ultimately lead to better patient safety environment in the hospital and reduction in the medical legal issues. So always remember that every patient is a potential litigant, and nowadays patients are becoming more and more informed. They are more empowered, they understand, they are more educated. So even if still there is a lot of power imbalance between the patient and the doctor, the patients are becoming more and more aware. Whether we like it or not, whether we agreed with or not, patients are becoming, and it is good for the overall system because they now can take their own decisions and they're better informed to follow those decisions. So every patient is a potential litigant. So if we keep that in mind, our behavior can actually change. Miscommunication sometimes can lead to disasters, and we all know there are so many examples of that. It can lead to, even ultimately lead to the death as well. Disclose all that patient must know. There is no need to hide, no need to think that they will not understand. Even if they don't understand, there is no harm in trying at least once to the patients or their attendant who can understand that, and document it that you have told them all that they must know. Collaborate, make patient a partner in your decision making. based on whatever time you have. I understand that residents are most of the time busy, they may not have that much of time, but you can always, try to make them partners in decision making, especially those decisions which are very important and can have serious consequences. Attitude and behavior toward patients, your behavior should always be empathetic, not just to the patients, but to the other staff as well. Just because we are doctors, we are faculty, or we are residents, this is not a reason to be rude to anyone. So be polite, be empathetic, especially to the patient, because patient is already going through a lot. And adding to his or her misery is not our objective, right? What we want is that we want to treat the patient, send him back home, him or her back home, healthy and hearty, and with dignity. So the treatment with dignity and empathy is very important. Informed consent, Dr. Hindu has taken a wonderful session already on that, and it has to be taken wherever it is needed. And always document. As I said, this is the thing that will save you in the court. If you have documented, if you have told them, many times I see the doctors say, oh, we did this, we told them, but this has not been documented properly. So there is no excuse for that. Based, depending on whatever time you get, don't neglect the documentation. And follow the SOPs, don't bypass SOPs for whatever SOPs you have for various procedures and all that. Those SOPs are there to be followed and not to be bypassed. And safeguards are for their safety and not for the bypass, including the SOPs. Also, whenever in doubt, ask others, ask seniors, don't hesitate. I always say no question is a stupid question. So never hesitate to ask questions to your seniors and never hesitate to ask questions to your peers, because that is how we learn. Everyone doesn't know everything. So instead of taking an action without properly understanding that, it is always better to ask and understand it from those who already know it. At the same time, it is when we are learning new things, it is very important what not to learn. Many times you see while you are as a resident working bad examples in your day-to-day practice. You will see people around you who, you need to consciously take a decision that not learn those things from them, right? They might be doing something. If someone is, rudely behaving with the patient, this is not something to learn. But what happens that sometimes we brag in coffee room others ki I did this to the patient, or I said this to the patient, or usko maine seedha kar diya, he was asking this and maine usko aise bol diya. These are things not to learn, because these are not going to help you. So in addition to what we have to learn, we also need to understand what we should not learn from others. Attend orientation and training programs. I have already mentioned this. And as I mentioned, medicine is a teamwork. So be a good sport. Everyone is important, whether it's a nurse or a hospital attendant, sanitary attendant, or a technician or anyone else. Medicine is a teamwork. We in isolation cannot work. If the sanitary attendant does not clean the ward in the morning, can we work there? So everyone is important. We don't have to be rude with them. We have to, develop this this environment of a teamwork. Breaking bad news, I think already a session has been taken. This is very important. At the same time, conflict resolution and conflict management is another issue, which is entirely a separate class. If you can see some of the TED Talks, or if you have time, you go some of the presentations, it will help you. You can read some books on the conflict management in the healthcare. Those can actually help you. And you can always go through some of the salient features of the Consumer Protection Act. These have recently been amended as well. And we organize in the department CME on the laws applicable to hospital. You are always welcome whenever we next organize that. In that, there is a session on the Consumer Protection Act as well. And read some of the landmark judgments and understand what went wrong in those issues, in those cases where the crores of compensation has been awarded by the court. So in the end, this is what I'll quote from Terry Canale. It said that the patient will never care how much you know until they know how much you care. So that your care is what they are seeking, for what they are. And I hope you will not let them down. So thank you very much. That is all from my side, and I'll be happy to take any questions if there are any.
So thank you, Mahesh, for a very elaborate discussion on medical legal aspects. And I know nothing is always elaborate or adequate. There is always a scope for learning more. And thank you so much for a very nice talk which you gave.
Thank you.
Now, before we go to our valedictory session, I would open the whole course for comments from anyone. We know that this time we have not covered medical errors, how to disclose medical errors by the doctors. And also we didn't talk much about residents' burnout, because that's another problem which interferes with their becoming professional. So these are the things which we otherwise cover in our workshops. But if you have anything, any comments to make, any one of you, you're most welcome.
I just need to have a little point of view. In patient communication, I think one major aspect of patient communication is also the communication with the patients have with our nurses. And I just have a suggestion that we need to include nurses as part of the communication program, so that and that's been a consistent observation that many times maybe the communication with nurses may trigger or in fact exaggerate a lot of conflicts, or you may say miscommunication could be enhanced if there is no effective communication with the nurses and the patient, because they are the first point of contact for many things.
I think that's a very good suggestion, and we had thought about it, but it was also said that probably this will be done separately for nurses and not, this part was more for residents and for faculty. The other course is the one which we have for faculty. But you're very right, nurses are extremely important, and if so many problems can be averted, if the nurses have communicated well, and doctors also, how they communicate with nurses is another very extremely important. You have to have that feeling of mutual respect and the team approach, which is many times lacking, on our floors. So that is something which we really need to consider.
I've kind of had a first-hand experience when we've been working with our stroke nurses. If we could just have one or two lectures, maybe
they're so
included in
good.
the
I mean,
same
I've met
program.
your stroke nurses. They're so good and, very responsive and responsible. So I think we can think of initiating a course like that.
We can include faculty from 9 faculty or someone.
Yeah, exactly.
Yeah, we can plan for nursing staff. Yeah, I mean, the initial whole idea was that overall should be covering all the staff who are dealing with patients, whoever end up communication. That could be doctors, nurses, or even reception staff. They also need communication skills. So the plan is there. We'll take it from here and try to get into, all the areas. Yeah. I had one thing just to add to that beautiful presentation about the angry patients. Another thing what we can do is, if we offer ourselves that if we are not able to satisfy you once the patient is angry and not cooling down, that you can always go and we have a complaint register and you can give a written complaint. So, one that gives an idea to the attendant or the patient that they care about my complaint. And the other is that if they still go and complain to the register, we may have a second chance of going and resolving their complaints rather than them going directly to a court or something. So that is something very useful we can do. Regarding consent, I had a point. Doctor said and discussed everything. In practicality, in all departments, that is for all of us, and especially, procedural, where we do procedure. And we have seen that although there is a lot of procedure and the accurate algorithms and forms, many times what happens is somebody just walks up to the patient or the attendant and asks them to sign. So after going through training, the second part is enforcement of this, that they actually talk to the people, not a printed form and just go and sign, which we all know many times, I'm not saying only about our hospital or anywhere else.
And all,
That getting enforcing that.
Just sign it, they've read it or understood it.
Absolutely, ma'am.
Definitely improved in this COVID times. I've seen a long consent by the surgeons also. Even our people are also more careful in taking the consent.
Maybe they have more time now because there are less patients.
In a way, yes.
No, I think we're more careful. Yeah, that is absolutely right. Yeah.
So,
Correct. Anyone from our guests, anyone wants to say something, we can ask them, or the...
Ma'am, I wanted to make a point and rather ask panel for their suggestions. Recently, the telemedicine has come up like a good tool to deliver effective the healthcare delivery tool actually. So a lot of bad news or maybe uh, things have to be disclosed on the phone rather than in person, like say for an example a malignancy which is being diagnosed on investigations. So recently there is a paper comment letter in JAMA also on this aspect, and people are discussing about how to actually deliver, and there are both arguments as well as counter arguments for delivering bad news on teleconsultation. So because one misses the actual empathy and the non-verbal cues while on teleconsultation, right? So what does the panel think about it? I mean,
That's an excellent, that's an excellent question or dilemma, I must say, Nipun. So my thought about that is, of course, there's nothing that if you're sitting then where you can physically comfort the patient or something is the best. So how I would think it is the situation. So once we're in a lockdown kind of a situation where there is nobody moving around, or a curfew kind of a situation, I don't think we are left with much choice as to if the patient wants to know. We can't delay it so that when they are able to come. But out of that, once we are over this situation, and hopefully as yesterday we were discussing, ma'am was saying, and we may carry on with teleconsultation in some cases where it may be a benefit that the traveling is gone. In those cases, if I look at that, maybe we could do a consultation. But if it comes to a very serious news, especially if the patient is not too far away or, in different cities, I personally, that's a personal thing, would still ask them to drop in with somebody with them, along with them, and do it face to face rather than do it on phone. So if you have a choice, yes, of course, physically. Otherwise, maybe on phone.
Yeah, but I feel that if one talks on, even if you're talking on telephone or you're talking on a video consult, it is possible to give useful information to the patients, because their ultimate aim also is to get well. So even if it is a difficult situation and treatment of that particular condition is difficult, one can communicate that to the patient party, because it's very important to let them know that this is a difficult situation and this is what will lead to the survival of, I usually talk to the parents of children, so they kind of understand it. But when you're talking to the patient himself, of course, you, I think, have to take in confidence someone he or she is close to. I mean, that attendant or that friend or that somebody has to be there to whom you can communicate in much better detail. But sometimes it's not possible because you're sharing the same screen or you're sharing the same thing. So it does get across to the patient also. So we have to think of these modalities. I think this is a very, very important question which Nipun has raised. And we really need to work out how we are going to do that, because it does need to be done, like these days we do have patients who are chronic disease patients, who are, say, cancer, or those who are chronic life threatening diseases like cystic fibrosis. They are at the risk of dying if something actively is not done at a particular situation. So one has to communicate to them, and somehow so far we are talking to patients who know us. But if it is an absolutely brand new patient, that patient also comes with some degree of confidence in you. That is why he wants to talk to you. And if you give this person an advice which is of serious nature, I think these patients these days would take. I mean, at the moment there is like a problem of patients being able to contact doctors. That's why so many companies, like Practo and all those have come up, who are advising patients online. So there is actually at the moment a scarcity of doctors being available to talk to the patients who need them, because the patients are not able to come to hospitals. So
another thing which
yeah.
sorry.
Yes, please. Yeah.
Another thing which is I think I've been observing, like I regularly I do a video consult with a lot of patients. It takes a longer time now. Like,
Yes.
for example, even on a regular day, stretching to maximum, we can go take 4 or 5 patients. At the same time, we used to manage much higher number of patients, especially if we are resorting to a very effective communication. And like you referred to patients who are sick. So I've had a few examples of motor neuron disease patients, but true enough, the first interaction or the first encounter for all these patients had been in hospital and they were on follow-up. So on a follow-up, we were able to convince them into at least taking certain steps. For example, in motor neuron disease, you need to maybe go for a percutaneous gastrostomy, etc. But in those scenarios, yes, the first instance had to be in person. And then we could follow them up and advise them for various modalities, even on the video. And they seem to be doing okay with that.
Yeah. Okay.
One thing.
So, yeah. Yes, Mahesh.
One thing I just wanted to add is that even with the telemedicine, we all emphasize that they should have a primary physician nearby. Like they should always have someone. They cannot just rely all the time on the telemedicine. They should have a primary physician or someone, provider, maybe a nurse provider or someone who they can always go to talk to, who can, which can take care of these issues when we cannot, communicate on the in the virtual world. So that support should always be there, even with the telemedicine.
Yeah, absolutely.
So I think that Dr. Mahesh, based on this, I think there is very strong evidence, at least in hepatology. We have recently seen one article which is published, and they showed that net promoter score, there was that was a criteria used to assess the satisfaction as well as the improvement rate. And they showed that it was close to 95% when there was this assistant available as well as the doctor talking on the teleconsultation. That was amazing. I mean, both the things, and it is evidence-based now.
Yeah.
Yeah. So I think now we will, because we are short of time, I think we can continue our discussion on our YouTube forum and also otherwise on our Fit PGI WhatsApp system. So that we keep interacting and getting suggestions. So we'll now like to thank everybody. You've been excellent talks. Actually, every time we listen to these talks, there's something new which has come up. So we'll now go on to our valedictory address, which is by Dr. Srinivasan. He is a director professor from JIPMER, former director professor from JIPMER, and is currently also involved in a lot of national level academic activities. So, sir, would you like to say, few words on this course and otherwise your suggestions and your experiences? So I think you have to unmute yourself.
Okay, I thought I have done it. Okay, so I appreciated all the excellent speeches and very up to the point, and they really covered such a short time. They have covered almost aspects of important points have been covered. So, of course, we can go on talking on these topics because times are changing. I can tell you when I was DCH and postgraduate, we were posted in General Hospital. Our campus was far away from town, and most of the people used to go and then to that hospital that I'm talking about 1969-72. And then we were the only doctors as postgraduates, and one senior resident from JIPMER will be the only 2 doctors with nurses to manage more than 30 to 40 admissions a day in the pediatric ward. And the consultants, the state government consultants, they work from 8 o'clock to 2 p.m. After that, they will never be there. They will be there in the practice. So virtually we were managing. And you can imagine those days we were having tetanus cases, we were having diphtheria, we were having diarrhea, dysentery, cholera, and so many cases of nephritis due to pyoderma, etc. And you can imagine, but still all these things, we have been managing, and we don't know how many we have been responsible for the death. But people had absolute faith. But things have changed. With so many private colleges cropping up and money has become the biggest lure for taking up medicine. So things have changed and the people's perspective about doctors have changed. And another important advance is the internet. Now most of them are educated and the parents, they consult the symptoms and they find various advices given on the internet. So especially this is very common in Kerala and states where literacy rate is very high. So they come with pre-formed opinions, and as Dr. just now mentioned, they take much of your time for us to convince them. Okay, so naturally, very important. And in the medical, of course, we have been conducting national teachers training course, and of course, one of your centers, the first three centers, Trivandrum, yourself, and JIPMER, and we have been conducting. And it's one important aspect of training is communication skill. Okay, communication skill, as just now stressed, between doctors and nurses themselves, because many a times the problems occur between doctors and nurses, and between doctors themselves. Say, for example, in the intensive care unit, junior doctors, sometimes will be there, and then the patients will come, patients will come at that time when a senior person is not there. So nowadays, of course, things have changed, and there is always a common platform. They meet in a room and then discuss about what is to be told and what is not to be told to the patient's relatives. And very important that because inconsistent views are given about the child's condition. Somebody will say child is very sick. Say for example, bronchiolitis suddenly would have deteriorated. And so people, know the previous person would have told the child has become sick and we have to transfer the child to the intensive care unit. But the other person will be giving an opposite this thing. So naturally, inconsistent responses from doctors who are on duty themselves have to be avoided. These are important things which will be discussed. And now, of course, in all the pre-rounds, nurses are also included what to say and what not to say to the patient's relatives when they come. And in case they are in doubt, they have to immediately contact the senior consultant who is available over the phone, or they can convince. And of course, all the videos which are shown, what not to do and what to do, has been, they are very revealing. And these are things which have to be told. And as I mentioned, in the medical education, what is important is nowadays in every bedside round, I am a person who is very fond of bedside teaching. I am supposed to be a better bedside teacher than a theoretician talking in lecture theaters. Okay, I may be boring, but they appreciated my clinical teaching of demonstrating science and talking to the patients, etc. And that's the time, now we have to talk about ethical considerations in that patient. So what are ethical things, and what is to be told, what is to be photographed, what is to be put in this thing before publication. You have to get the permission. So these are important. Ethical considerations are very important, and also we have to discuss about medico-legal considerations. So especially, it may not be done in front of the patient or relatives. Of course, in the side room, it has to be told, and what to be told and what not to be told. These are all very important, essential things. And of course, I will not prolong your agony. So now things, of course, many medical colleges have taken up this type of teaching and counseling techniques. Okay, counseling to the parents, counseling to other relatives. But problem is nowadays, it's really political interference, and people, they barge in big numbers just to create trouble. Okay, that is, no, these are the people should be strictly avoided by the administration. Only people concerned and totally involved in the patient care and the relatives or near relatives only should be. Otherwise, every time we cannot go on explaining, our time is wasted. So there are certain administrative regularities also that have to, regulations that have to be taken care of. And I'm sure we are going in the right direction, and things are constantly changing. And with awareness and as well as medical legal, just now I sent you one message. The government has strict, no, just now I received in my 1964-69 MBBS batch that strict punishment will be given to people who are creating troubles to doctors and nurses, because assault has become so much. Recently, you must have heard about the Kerala incident. So it's very important that we look at this problem very often, and this education, medical education should include this counseling part as an important thing. Many medical colleges have taken up, and how to talk to the patients, how to be polite, how to empathize, and is very important. I'm sure we are going the right direction, but much more has to be done. And of course, because mushrooming of medical colleges and the various nursing colleges also without proper training is one important aspect to be considered. But things are improving there also, because nowadays people are really passing a exam, okay, pre-medical test. That has made a lot of difference in the type of quality of doctors who want to take up medicine. Of course, after this beating and COVID season, probably medical seats will be going begging in many of the private medical colleges. They will try to choose some other profession, because many of the doctors themselves are infected with COVID and their life. So many doctors have sacrificed lives. Nurses also have sacrificed. So people, I think the craving for medical education will come down, and people are really interested in doing good to the patients only will take up, I think. So I think there is hope. There is always a light at the end of the tunnel, and your this type of educational input by you and your team, they are very essential, and you are doing a wonderful job. I appreciate you. I thank you for inviting me for this valedictory function. Thank you so much.
Thank you. Thank you so much, sir.
Speakers, they have done a very good job, and I enjoyed your talk very much, and I'm sure it will be very useful. And this type of continued activities, continuing education to undergraduates right from the first year, because nowadays first year itself they go to the clinical bedside. So how to behave with the patients, this code, because many a time now we find we can't differentiate between a father who has been there for 3 days without taking and a boy. They are all coming in jeans and this thing. So there is no difference between film actors, relatives, and a doctor. So I think some dress code is very important, so that some respect is there for the profession. Thank you so much.
Thank you.
Yeah, absolutely right, sir. I mean, this type of discourse which we are having from you, sir, it was quite an essential thing, when we also had the National Teachers Training course, and somehow it was discontinued. So, like this course which is there now, right now, which what we are doing is a kind of offshoot of that course, because this is what we say that, teaching residents in the effective domain. And
we also teach about how to tackle these medical representatives. So how
yeah, yeah, that's another thing.
the antibiotics,
Yes.
everything. And then and so many unnecessary non-essential medicines are given, and they cause problems, drug interactions. So it's very important that not only this thing. So
That's absolutely right, sir. We know of prescriptions on which 10 medicines are written and 3 of them of the same kind. And they are just to please the medical representatives. And so it is not just how to talk to them, it is also how to shoo them away, actually, sometimes. When
waste your time, and finally we don't have much time in the private practice for patients. They take half an hour, 2 hours, showing all the pamphlets and pushing in drugs. Whereas the patient has only 10 minutes or less than 5 minutes for telling the complaints, etc. This is the main reason, because there is hardly any time. As just now mentioned, nowadays I am seeing only 5 patients. Previously used to say 10 patients, because so much of questions are being asked, and we have to patiently answer all their doubts, etc. Thank you so much for giving me this opportunity. I enjoyed the interaction and the
Thank
talk.
you, sir. Thank you. Thank you for being with us. Yeah. Thank you so much for being with us. And now I thank everybody, and especially Dr. Geeta. Today she could not be with us because right now it must be past midnight there. So I think she said that she would listen to the recording today of the today's session, and we'll see if there are any. There are no questions so far coming on the YouTube also, and but like there were more than 250 hits yesterday of the yesterday's session. So I'm sure the residents are able to see them later on, because sometimes they are involved in their duties and all, and they're not able to join us right now online. So with that, we thank everybody. So this is the end of our course for residents, and thank you so much. Thank you, sir. Thank you, everybody.